Welcome back to Audioboards. Today we are breaking down the newly released KDIGO 2026 Clinical Practice Guideline for Acute Kidney Injury and Acute Kidney Disease. This is the first major overhaul since 2012, 14 years of data finally consolidated. If you are still managing AK, like it's 2012, your board answers and your clinical practice are out of date. Today, we're cutting the fluff and giving you the exact comprehensive breakdown you need to master this topic on rounds and on the exam. Let's start with the big conceptual shift. KDIGO 2026 formally introduces a continuum. It's not just AKI anymore, it's the AKI-AKD-CKD continuum. Think of it as a rolling clock based on duration. A KI, acute kidney injury, the acute window lasting from 1 to 7 days. A KD, acute kidney disease, the subacute phase covering 7 to 90 days of kidney injury or impaired function. CKD, chronic kidney disease. Anything persisting beyond 90 days officially crosses into CKD territory.
Now let's look at how we classify and diagnose what's actually happening to the kidneys. Every medical student learns the classic triad: pre-renal, intrinsic renal, and post-renal. Does the 2026 guidelines still use this framework?
Absolutely. The basic anatomy hasn't changed. Post-renal is still your structural or functional obstruction. Think BPH, neurogenic bladder, or bilateral stones. You rule it out early with a bedside bladder scan or a formal renal ultrasound, but where the 2026 guideline fundamentally changes the game is how we differentiate between pre-renal volume depletion and intrinsic renal damage like acute tubular injury, ATI.
Right, because historically on the wards, everyone looked at the fractional excretion of sodium, FeNA, or fractional excretion of urea, FA-urea, to tell them apart. If the FeNA was less than 1%, we called it pre-renal and opened the fluids. If it was greater than 2%, we called it ATN and stopped. What is the updated verdict on those diagnostic formulas?
The guidelines explicitly warn that traditional indices like FeNA have massive diagnostic pitfalls, especially in critically ill patients or those already on diuretics. Instead of relying on rigid arbitrary chemistry numbers, KDIGO 2026 utilizes the new staging framework to redefine this concept. And this brings us to the biggest structural change in the guidelines: how we stage AKI. For over a decade, we relied entirely on functional markers, serum creatinine, and urine output. What's the major upgrade now? We have officially entered the era of structural biomarkers. The new staging integrates functional changes with structural damage markers like urinary TIMP2, IGFBP7, and NGAL. B0 means no structural damage. B1 means positive structural biomarkers. This lets us identify damage without dysfunction, where the creatinine hasn't bumped yet, but the kidney cells are under severe stress. That bridges perfectly back to the pre-renal versus intrinsic debate. True functional/pre-renal AKI maps to stage B0, positive functional changes from hypoperfusion but zero structural biomarkers. Intrinsic renal AKI maps to stage B1, the tubules have sustained true parenchymal injury, causing the biomarkers to spike.
The 2026 paradigm shift treats pre-renal and intrinsic renal not as isolated independent buckets, but as a clear transition point where uncorrected functional hyperperfusion transforms into structural cellular damage.
Exactly, and this updated staging system directly dictates our management, starting with fluids. In the past, the reflex for a rising creatinine was open the IV fluids. What does KDIGO 2026 say about fluid and hemodynamic management? The pendulum has swung heavily towards strict fluid stewardship. The guideline explicitly warns against aggressive, unmonitored fluid resuscitation unless the patient is overtly clinically hypovolemic. Once a patient is fluid resuscitated, fluid accumulation and fluid overload are independently harmful to the kidneys by causing venous congestion.
And what about the choice of fluid? Are we still running normal saline by default?
Definitely not. The guideline recommends balanced crystalloids, like lactated ringers or plasma-light, over 0.9% normal saline for the prevention and management of AKI to avoid hyperchloremic metabolic acidosis, which worsens renal vasoconstriction.
Let's talk about vasoactive medications. If we have a patient in septic shock with or at risk for AKI, what's our pressor of choice?
Norepinephrine remains the first-line vasopressor to maintain a mean arterial pressure, MAP target, usually starting at 65 millimeters of mercury, to preserve renal perfusion pressure. For hepatorenal syndrome-associated AKI, Look out for standardized vasoactive therapy updates, prioritizing agents like terlipressin or norepinephrine combined with albumin.
Perfect. Let's move to a massive topic that always gets tested: kidney replacement therapy, KRT, timing. For years, there's been a fierce debate. Should we start dialysis early to rest the kidneys or wait? What is the final verdict?
The data from major clinical trials over the last decade is clear, and KDIGO 2026 gives it a grade 1C recommendation. Choose a deferred strategy over an early, preemptive KRT strategy.
Let's pause there because that is an absolute board favorite. A deferred strategy means we watch and wait unless absolute emergency indications are met. Walk us through those classic life-threatening emergency indications, the AEIOU parameters that mean we cannot wait.
Exactly. You wait until the patient actually needs it. The standard emergency triggers are refractory hyperkalemia, severe non-responsive to medical therapy, severe refractory metabolic acidosis, refractory volume overload causing severe hypoxemia, uremic complications like pericarditis, encephalopathy, or intractable neuropathy. If they don't have those, watch, wait, and give the kidneys a chance to recover on their own. Starting too early increases complications and doesn't improve mortality or dialysis independence.
What about the modality and dosing of KRT for our critically ill patients, continuous versus intermittent?
For hemodynamically unstable patients, the guideline recommends CRRT, continuous kidney replacement therapy, or acute peritoneal dialysis over intermittent hemodialysis (IHD) to minimize rapid fluid and solute shifts. As for dosing, the standard CRRT effluent volume target remains standardized at 20 to 25 milliliters per kilogram per hour, grade 1B.
And a huge do not do warning in the guidelines: high volume hemofiltration, HVHF.
Yes, the guideline explicitly recommends against high volume hemofiltration doses greater than or equal to 45 milliliters per kilogram per hour in septic shock, grade 1B. It doesn't help outcomes, and it actively harms patients by clearing out essential nutrients and antibiotics.
Speaking of medications, let's look at nephrotoxin stewardship. What are the key rules for managing drugs in AKI?
It boils down to a multi-component strategy. Stop unnecessary nephrotoxins, adjust doses based on current kinetic GFR, not just baseline eGFR, and utilize therapeutic drug monitoring, TDM. The guideline heavily emphasizes involving clinical pharmacists to review drug-drug interactions and avoid drug-induced crystalline nephropathies.
What about contrast associated AKI-CAAKI?
The 2026 guideline emphasizes a nuanced approach to risk assessment. For high-risk patients undergoing contrast imaging, volume expansion with balanced crystalloids is recommended. It's all about calculating the true risk based on contrast volume and baseline eGFR.
To wrap things up, what happens after the patient survives the acute episode? They get discharged, creatinine is down. Are we done?
This is a major new focus area. Because of the AKI-AKD-CKD continuum, patients who survive an episode of AKI or AKD are at extremely high risk for cardiovascular events and progressive CKD. The guideline now mandates a structured kidney health assessment and follow-up care within 3 months to monitor for resolution, optimize blood pressure, and review medications. Let's do a quick fire recap. The continuum: AKI is 1 to 7 days, AKD is 7 to 90 days, CKD is greater than 90 days. Classification: rule out post-renal early. Treat pre-renal and intrinsic renal as a continuum. Staging now incorporates structural damage biomarkers, B0 versus B1, to find damage without dysfunction. Fluids: use balanced crystalloids. Practice strict fluid stewardship to avoid fluid accumulation. KRT timing: favor a deferred strategy unless life-threatening emergency indications exist. CRRT dose: target 20 to 25 milliliters per kilogram per hour. Do not use high-volume hemofiltration. Follow-up: check them within 3 months. The injury doesn't stop at discharge. Thanks for listening to Audioboards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the Audioboards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.